All right, Ani, take it away.
All right. Good evening, everyone. Welcome to our 55th virtual shadowing session. Tonight, we're going to be joined by Dr. Paresis, who's going to be talking about radiology, and he'll introduce himself real quick. I'm just going to go through some brief introduction. So this is our team. We have Dr. Fowler, Dr. Marchetti, Dr. Salazar, and Dr. Reno, as well as the rest of the working group that helped to put together all of these sessions before. Here are some upcoming sessions. So next week we have 3 sessions actually. We have our normal sessions as well as 2 bonus sessions. So as far as the bonus sessions go, the session on the 24th will count for credit and the session on the 23rd will not count for credit. And here's the rest of the session schedule. And I was told to give you guys a reminder, but the contest for the mock interview does close tomorrow night, so be sure to enter all of that. And be sure to follow our Instagram. Be sure to check our emails, and we'll post any updates about future sessions and all of that on that. Now, for the Q&A sessions, we're going to have 2 Q&A sessions during two Q&A sessions during the presentation. There'll be one in the middle and one at the end. So be sure to put all your questions in the chat, and we'll curate all the messages and make sure to answer those.
And then Ani, can I interrupt real fast?
Yeah, go ahead.
So we already have in the chat that questions about our upcoming bonus sessions. So the session on the 23rd is going to be a PA student panel. So you can ask some PA students about how is it like getting into PA school? What is the application like? Tips on interviewing? How is PA school like, and how to balance life? And then the session on the 24th is going to be a PA spotlight orthopedic surgery. So if you're interested in that, please stay tuned. And again, yeah, like Ani said, our contest over mock interviews or for a mock interview closes tomorrow night at 11 p.m. Central Standard Time, or 11:59 p.m. Central Standard Time. But be sure to enter that. We will contact the winners on Friday. Thank you, Ani.
Awesome. And I'm going to stop sharing my screen now, but I'll give it to Dr. Fowler if you have any announcements to make.
That's great. And Nick, go ahead and pull your talk up, and we'll get started in just a moment. So welcome, everybody, all 260 of you. It's so good to have you back. We've been going now for 1 year and 2 weeks and 55 lectures now, just amazing. And it's amazing that it's found a need all over the world. And we're just absolutely delighted to have you all back. We've had over 250,000 views of the talks. I mean, it's astonishing, in 36 nations, over 1,000 universities. So you've made virtual shadowing what it is. And so we're going to keep being here. If you want us to keep coming, we'll do it. We've already reviewed, Reagan and I last week reviewed, we went through the American Board of Medical Specialties to pull out those subjects that we have not yet covered, because we want to keep them current. We want it to be fresh. And we've had a terrific virtual shadowing working group, half of whom are going off to medical school soon. So we'll be replacing that, some of the ones going away with some others. And so we are looking forward to having you back. And so without further ado, I will, Ani, you want to introduce our guest of the evening?
Yeah, so our guest for evening is Dr. Paresis. He's a radiology resident. He's going into his radiology residency. He's in his transitional year right now. And I'll actually pass it over to him if he wants to go ahead and talk about his journey and whatnot.
Well, thank you for the invitation. I think these shadowing sessions are such a great opportunity given the pandemic. So kudos to everyone who has coordinated all of this. And today, I think we're going to talk about mostly the specialty of radiology. We'll talk about a little bit of my path through medical school. We'll talk a little bit about medical school, and then about the specialty of radiology, in addition to artificial intelligence and what those implications might be for the specialty in the future. We'll stop for a Q&A session in the middle, and then we'll pick things up with more clinical cases, imaging like x-rays and other types of scans and go over some really basic anatomy, and then take more questions at the end and kind of wrap things up. So if you aren't following me on Instagram and TikTok quite yet, go ahead and do so. My handle is right here at Dr. Paresis. I try to be fairly active on there, and I definitely check my DMs every day. So please feel free to reach out with any questions. People send me questions every day, whether it's about COVID-19, the vaccines, pre-med stuff, medical school, residency, radiology. So lots to talk about. So we'll jump into things. So I thought a good way to start describing kind of my path is talking about where I'm from. So I'm from a small town outside of Sacramento in Northern California called Stockton or Lodi. And I grew up there. I was born there. And at 18, I moved to the University of California, Santa Cruz in kind of the coastal part of California, in Northern California, about 2 hours south of San Francisco. And so at UC Santa Cruz, I majored in molecular and cell biology. And at that time, I also played collegiate rugby. So I played D1 rugby for 4 years, and wasn't really sure if I would go to med school or not. I thought I always wanted to do something in healthcare, but I wasn't quite sure what. I didn't have many mentors in my life, but I think I was surrounded by the right people, and I think I made the right choices. So after undergrad, I had to take 2 years off in order to kind of get my stuff together, take the MCAT a second time, get my letters of recommendation in line, write my personal statement, et cetera, and so on. You guys know the drill. So I took 2 years off, and I worked in Minnesota, in Minneapolis, based on his recommendation. So I think that shows the power of networking. So now I'm currently in my first year of residency. I'm finishing it. I'll be starting radiology full-time for the next 4 years. And I'll be in Minneapolis for that, in the Twin Cities. So some of my hobbies include playing rugby. I played rugby in college. I also play traditional Greek folk music. I posted a little bit about this on my Instagram if you guys want to check out those posts. And lately, social media has been a really big hobby of mine. And it all started about a year ago when I was posting about COVID-19 and the science behind the pandemic, kind of explaining things and desensationalizing the headlines that people were reading, kind of explaining things from a medical and scientific standpoint. And I'm continuing to do that on my medical page, but also now doing things like this, where I talk about my specialty of radiology, as well as medicine and medical school in general. So a little bit about myself. Med school is described as drinking out of a fire hydrant. The only way to handle the information that is coming at you is by coming in every day for little sips. And you have to do this every day. Otherwise, you will just get blasted with information. So it is definitely manageable, but you have to come in for small sips each day, I think, is the key. Another good way to describe medical school is like eating a stack of pancakes for breakfast, lunch, and dinner. You know, if you have pancakes on like Saturday morning at brunch, pancakes are great. And the things that you are learning in medical school are great too. All the physiology, the pharmacology, the pathology, it's all really, really amazing. But you have to do it every day, so it can get old, right? Eating a stack of pancakes every day, 3 times a day, can get old. So you really have to pace yourself. So I thought this was a nice meme to kind of color your understanding of medical school. So there are a lot of misconceptions about radiology and what a radiologist does. So some people think that we just speak into a microphone here. Other people think we do some sort of surgery, which is partly true because we do minimally invasive procedures. Some people think we just drink coffee and hang out. And we'll try and address some of these misconceptions as we go through these slides here. So this is kind of what a radiology workstation looks like. So we have these 8K or 6K monitors, super high resolution. They cost like $10,000 to $20,000 each. And we pull up our scans and we dictate into a microphone what we think the findings are on the imaging. So these imaging studies might be x-rays, CT scans, ultrasounds, MRIs, nuclear studies, and we also use fluoroscopy, which is a type of live x-ray where we can see the anatomy of the human body in real time and then use that to do a procedure like put a needle or a catheter or a tube in a part of the body in order to diagnose and treat disease. So this is kind of what the workstation looks like. It's as close as you can get to a computer job, I think is the best way to describe it. And radiology really is the eye of medicine. So oftentimes we can only get so much from talking to a patient and doing a physical exam and ordering some blood work and other types of tests. But sometimes we need to look inside the body with certain types of technologies that I've listed here. So these all serve different functions and are good for diagnosing different types of diseases. So the radiologist basically focuses on making the diagnosis, but we also treat disease by doing certain types of procedures. And we basically look at the imaging, create a report, and then the report goes into the electronic medical record. And this report helps the doctors on the front lines, the emergency doctors, the internal medicine doctors, the primary care doctors, and the surgeons to make a decision about what to do with the patient, about what the best next step might be. Should we give this patient medicine? Does this patient need surgery? Does this patient not have any anatomic pathology or disease on imaging? So we basically help guide the clinicians on the front lines. And so we do certain types of procedures that I'll talk about in the slide in about 20 minutes or so. But we also take care of patients. So some people think that radiologists maybe don't interact with patients much, but there are two specialties that actually have a lot of patient interaction. Those would be breast imaging and interventional radiology. These specialties actually have clinic where the radiologist needs to see patients in the clinic, and there's a lot of patient interaction there. The other specialties definitely have less interaction, but your day is broken up by doing procedures and talking to patients throughout the day, in addition to kind of the bread and butter of reading imaging studies and doing diagnostic work. So we still do see patients. So it's not like you get to see, it's not like you go to radiology and you never see a patient again. So some of the other things that we do as radiologists is something called protocoling. So protocoling means that we help the providers, the PAs, NPs, MDs, and DOs figure out which test is the best one to order, depending on what they're looking for. And we help basically guide them, like how to order it. Like, does this patient need, like, does this study require contrast or no contrast, for example? And contrast helps us see different things in the body differently. And on that same note, we also have to prescribe medicine sometimes because patients can have contrast reactions to the medicines that we give in order to see better with imaging. So you might give a patient Benadryl, for example, or steroids to medicate them so that they can get the study and ultimately have their condition diagnosed. We also interact with radiology technologists, and these are the people who are actually taking the x-rays and taking the patient to the CT scanner and having them scanned. So they are highly trained in acquiring the images. And then where the radiologist fits in is that they are trained in the anatomy and helping kind of medical management. So we interact a lot with the radiology technologists because they oftentimes have questions that we help them work through, and they also help us. So we also learn about radiation safety. I think a good thing to know is that the radiation approximately from an X-ray is the same as flying from New York to San Francisco about 3 times. So there's a baseline level of radiation that human beings are exposed to just from basically living. And so there is some radiation from flying as well, because you are, of course, closer to the sun. And if you compare this to CTs can have anywhere from 10 to 100 or even 1,000 times this level of radiation from an X-ray. So an X-ray is kind of like a bad sunburn, right? So CT scan has much more radiation than a X-ray would. And the type of radiation that I'm talking about here is called ionizing radiation. This is compared to non-ionizing radiation. Studies that have non-ionizing radiation are things like ultrasounds and MRIs. So ultrasounds and MRIs do not increase the risk of cancer, which I think is an important takeaway. If you stop here, just know that CT scans have give the most ionizing radiation dose and thus increase the risk of cancer the most. So try to avoid these in children, and also just try to limit them when possible in patients who need a lot of CT imaging, like when they are very, very sick in the hospital. So hope that kind of colors your understanding of radiation safety. We do learn a lot about radiation safety in residency. We also learn about physics, which I think is something that is somewhat unique to our specialty, as well as radiation oncology. So this isn't like the type of physics like you might learn in college. It's a little bit different. It's more medical physics. So we kind of get the dumbed down version because there are people with PhDs who study medical physics for their entire life. And then they kind of refine what the medical physician needs to know about physics. So we have physics on our boards, and of course need to study it and learn it along the way. This is very different from like kinematics and other types of physics that you learn in undergrad, and it's definitely doable, but just know that that lies in the future of the specialty if you choose to go into radiology. So I wanted to share this slide because this is the very, very first x-ray ever taken. I believe this physician's his last name was Röntgen, and this is his wife's hand, and this is her wedding ring. So I'm just showing this here so that we have some sort of reference point to compare the types of imaging studies that we currently have when we get towards the end of this presentation. So a little bit of history. That x-ray is from about, over 120 years ago. So this is a funny cartoon because this person's father is saying, this kid's playing Nintendo or video games and saying, you'll never amount to anything staring at that screen all day long. And then 30 years later, I'm glad you made something out of yourself and stop staring at that screen all day long. So radiology is, if you are looking for a desk job, this is as close as you can get to it. It really is a computer job or kind of like a tech job. And that is something that I thought was pretty cool because you can just show up to your workstation. It's clean. You don't have to bring you don't have to bring anything with you besides like your knowledge and your mind, which I thought was an incredibly powerful tool because you can just show up and based on the knowledge in your mind, you can help like a patient that is on the other end of that of the computer screen and kind of help their medical management and possibly even save their life. So really, really powerful stuff. That said, radiologists do a lot of their work, a lot of their reading in a dark room. So it's kind of a funny meme because it's saying this is a radiologist asleep at night at home and it's dark. And then at work during the day, it is also dark. So the reason we have the lights kind of dimmer, it's not completely pitch black, but the lights are dimmer because it increases the contrast for our eye to kind of perceive more detail in the imaging when we're looking at things like x-rays, for example. So, this was an aspect of radiology I thought that might have turned me off from the specialty. But once I rotated into the specialty, I realized how much variety there was. And this isn't the only thing in radiology, and this really didn't even bother me. This whole, kind of darker reading room work setting. I actually thought it was kind of nice. So this is kind of what a radiologist's day might look like. So this is the radiologist at breakfast, radiologist at work, kind of dictating the studies in their dictaphone. And this has scribing software. So this has software built into it, like Dragon Dictation, some of you may have heard of, and it picks up all of the medical jargon that we use in order to populate the radiology report. This is a radiologist at lunch eating pizza, frustrated radiologist taking a break, having some coffee, tired, driving at home, dinner, playing on their computer, I suppose, and then at bedtime. So throughout the day, we spend a lot of time at the computer, but we also have this time at the computer doing our diagnostic work broken up by doing procedures, by also consenting patients, talking to them about the procedures that they're going to have done and what they might expect from it, talking to them about the risks and the benefits of this procedure. We do protocoling, which I talked about earlier, like which study is best to order. So we'll spend a lot of time on the phone with another doctor. So there's a lot of doctor-to-doctor conversations in the radiology workroom. This time is also broken up by teaching. So once you get to a certain point, like let's say in the morning from like 7:30 to 12 o'clock, then you'll take breaks throughout the morning in order to have the attending teach you as a resident. So there's a lot of teaching. So if you enjoy teaching and you want to do that as an attending, you will have lots of opportunities to do that. So we spend time on the phone. We also spend time doing research, of course, teaching, research, mentorship, all of that kind of goes along really nicely in our specialty. And I just really like how research driven it is, how evidence based it is, and how much of an emphasis there is on teaching. That also means that there is an emphasis on studying. And then, depending on your specialty, you might also have to go to clinic. So if you are in breast imaging, then you'll have patients to go see in clinic and talk to them about their mammography results, for example, and then you might have to do a ultrasound guided biopsy. So this is the kind of general medical activities of the general medical doctor. And a lot of this time is not really spent with the patient. You might have an image in your mind of spending a lot of time at the bedside doing patient care. But a lot of times your time is spent on the computer, on the electronic medical record, typing away and documenting, and ultimately to satisfy insurance and billing and things that maybe aren't as important to a physician. There's also a lot of time that's spent, waiting for scans, waiting for imaging, waiting for labs to be drawn, for blood work to come back to result, patients to get transferred, et cetera, and so on, waiting for certain consultants and specialists to give you the recommendations. So it's a lot of lost time. And I really liked radiology because we didn't have this so much. It's more, your work is much more direct. Your time is spent focusing on the science and the pathology and looking for disease and understanding the anatomy, and then really interacting with other physicians. It's a much more direct medical interaction, if that makes sense. So in order to kind of demonstrate that, these are the hours per week that a radiologist spends on paperwork and administration, because this will give you an idea as to the specialties that do this more, kind of up here, and these are the specialties that do this less. And this is an extreme positive in my opinion. So just depends on what you want out of your job, but I hope this kind of helps color an understanding of the hours that we spend doing kind of these non-medical activities. So thought I'd start by sharing also 5 reasons why I chose radiology. So the first reason is because radiologists have a direct impact on patient outcomes. So if you think about it this way, if I can read 100 scans or 200 scans or 150 scans, that means that 150 patients have come through my computer and I've helped that many people. So you can have a really large impact on patients and their lives. And this interaction is, like I said earlier, is a lot more direct. So you don't have this time that's kind of lost to paperwork and bureaucracy, and you kind of focus more on anatomic pathology. You're not spending time ordering things at the pharmacy or doing a lot of chart review or calling insurance companies and figuring out what's going to happen with this patient, like where are they going to go at the end of their hospitalization? What is their disposition? Do they need acute rehab? Do they need social work to help them get to housing, for example, or a skilled nursing facility, et cetera, and so on. So I didn't find myself kind of enjoying that side of medicine. So you'll kind of figure out what you enjoy in medicine as well as you kind of go along your path. So I also really enjoyed kind of the breadth and diversity of pathology. I loved how broad the specialty was. I wanted to be a generalist, but also a specialist at the same time. So we have so much, we have so many, we cover all of the organ systems, and then we cover them again because we have to learn each organ system and their diseases and what they look like on ultrasound, CT, MRI, and X-rays, and nuclear studies, and fluoroscopy, right? So you have to learn everything over and over and over. And it's just it gives you a really broad knowledge, but also very deep knowledge in medical imaging and anatomy. So I thought that was really, really cool. Some of the rarest diagnoses require imaging to call them or to confirm them. And some of the sickest patients, some of the most complex patients in the hospital who are in the ICU, for example, in the intensive care unit, they require a lot of imaging. So this makes for a very interesting specialty because we see rare cases and very complex cases that other doctors may not. So of course we see them on the computer, which is a little bit different, but it still makes it for a very interesting specialty, I think. I also found the specialty to be relatively innovative and cutting edge. And, I started reading more about artificial intelligence and how the radiology community is really embracing it as a tool to help us become better radiologists in the future. So I thought that was amazing. Of course, there are other specialties that are embracing artificial intelligence. I think dermatology and ophthalmology and pathology are also using it quite a bit. So yeah, we'll talk about AI towards the end of this. And as I kind of alluded to earlier, there's also a big emphasis on teaching, on doing research. And of course, that means there's a lot to know. So that means that radiology residents have to study a lot. So the studying never ends. So instead of saying that we are lifelong learners, I like to say that we're just eternal students, because you'll just continually feel like a student, even though you are a physician. You'll call yourself doctor. We are really eternal students, and there's no way anyone can cram any of this information. You have to just study. Kind of space it out. It's like a marathon, right? You can't just fit in all of that studying into a couple of weeks. There's no way to do it. So please don't get overwhelmed by the amount of knowledge that you need to know. As a physician, it will all come to you. Other people have come before us and have done it, and you can too. So if you ask radiologists on a survey, this is a survey from Medscape, would I choose the same specialty? Here you can see it's about 93%. So I think that's pretty good, especially considering that on average, about 50% of physicians would not tell their children to go into medicine. So I saw a lot of people going into the field of radiology from other specialties, switching into the specialty from specialties like even orthopedics, internal medicine, psychiatry, vascular surgery. So I was like, oh, this is interesting. But I didn't see people really leaving the specialty at all. I noticed that was very rare, if not just infrequent at all. Like, does it even happen? I think people just come to the specialty and stay. So I thought that was pretty cool. This is another cartoon kind of illustrating the same point. This is the physician pain scale survey from Medscape again in 2018. I'm living the dream, and you can see kind of the specialties that land up here, and radiology is up there. So I think that's pretty cool. You can see the specialties that are over here, but that certainly should not discourage you from pursuing these specialties. But just keep in mind, like, can I do this job for 20 years, 30 years, 40 years? Can I do it if I need to work for another 5 or 10 years after the age of 60 or 65? So I think job satisfaction is extremely important. So just some things to keep in mind. A few more reasons about why I chose radiology. So I talked about people switching into our specialty from other specialties. Another decision tree in your mind as you go through this very long path of becoming a physician is, do you see yourself more as a thinker or more of a doer? And this is, of course, not black and white, but it just depends on how you want to be solving problems, right? So I found myself to be much more of a thinker. Like, I enjoyed working with my mind much more than I enjoyed working with my hands or doing physical things like procedures. So it just depends on what you want out of your work. Some people want to be doing procedures 100% of their time and really want that for their life. And some people want a mix of both. So you can have a mix of both, or you can do mostly diagnostic work where it's a lot of thinking, right? The reading room is, if you can imagine, one of those workstations that we saw earlier with the 4 or 5 computer monitors. The reading room has basically can be anywhere from 3 to 6 of those different workstations where the radiologist is sitting. And it's generally a lower stress, not so noisy environment. It's a little bit dim so that we can see the contrast on the imaging a little bit better with our eyes. And I saw myself kind of thriving in that. You don't have people yelling in the hallways or someone vomiting or, ICU bells and those really high-pitched noises from the ventilators in the intensive care unit. You don't have bells and whistles going off. So I just wanted kind of a more relaxed, kind of chill work environment. So, and I would say overall, the specialty has a pretty diverse range of personalities and types of people who are attracted to it. Some people might say that, it's a lot of introverts and people who are socially awkward and don't really enjoy going outside, but I think that's not true. I think overall, if you can, of course, stereotypes never really help, but I think in general, people are chill and humble and laid back. So it's nice to have that in your colleagues, in my opinion. So one thing I heard was that imaging these days is kind of the physical exam of the 21st century. So what does that mean? So physical exam means that, you take your stethoscope, you listen to the heart and lungs, listen to the belly, press on the belly, you touch the patient, you palpate them, and see, and you do certain maneuvers to see if you can diagnose them with a physical exam, but oftentimes you cannot. So sometimes patients will be obtunded, lethargic, sedated, they have overdose, or they have a breathing tube in, they can't talk, et cetera, and so on. They might have altered mental status. So sometimes you just need to scan them. So I thought that was pretty cool that, radiologists kind of hold the key to a lot of answers. And, of course, a thorough history and physical exam is extremely important. Definitely do not discount the importance of this. But sometimes the CT scanner is simply just the donut of truth. The patient goes in, you get a scan, and then you get a radiology read, and it has all the answers. So this is another cartoon kind of illustrating the same point here. So in med school, you learn about the physical exam, how it's extremely important, and it is, but sometimes you just gotta order the scan. So that's where the radiologist fits in. That's kind of where our expertise fits in. So a few more reasons why I chose the specialty. Clearly, I can talk about this for a while. So one reason was because of the multitude of fellowships that you can do and the amount of flexibility that affords. So you can do interventional radiology, where you're doing so many procedures. You can do breast imaging, where you're focusing on mammography, breast cancer, women's health, and public health. You can do things like musculoskeletal radiology, so bones, sports medicine, orthopedic stuff. Neuroradiology, where you're focusing on the brain and spinal cord and interacting a lot with neurologists and neurosurgeons. You can even do pediatric radiology. You can do abdominal radiology and even nuclear medicine. So quite a lot of variety to kind of figure out, how much, and, all of that variety gives you a lot of flexibility to kind of pick and choose to see how much patient interaction you want, how many procedures you want to be doing throughout your workday. And if you want to be in a high acuity setting, like emergency department, or a lower acuity setting, like more of a community private practice, outpatient imaging center. So there's quite a lot of flexibility. You can work academic, private practice, rural, urban, national, international. You can work from your home in your pajamas or in your underwear, reading your X-rays. So just really whatever you want out of life, which is quite nice. And you don't even have to pick one thing, right? You can kind of switch it up and do, if you get tired of one thing, you can kind of change your workflow, which is pretty cool and pretty unique, I think. So something that I also heard when I was exploring the field of radiology is that radiologists are kind of like the doctor's doctor. So we are consultants. So if anyone has any questions about the imaging, they can just come down to the reading room and have a conversation. Or they can just give us a phone call and we can talk about it. Or we can talk about it at a conference. Or, oftentimes the neuroradiologists, the neurosurgeons, and the neurologists will have a weekly conference where they talk about the imaging and kind of what is happening from a medical management standpoint with the patient. So I thought that was a pretty cool position to be put in. It's not to put any other doctors down. Of course, we're all colleagues at the end of the day. And no, any one doctor's work is not less or more important than anyone else.
Hey, Nick, what has really impressed me over the years, and this is over 40 years, working now at a very full service hospital, Parkland, where we have everything of every specialty, especially radiology, covered 24/7, is that, in a way, having the ability to do scans and have the radiologists read them for us, in a way, I think that we perhaps don't complete as deep a differential diagnosis as maybe we used to back in the old days. Do a minimal history, minimal physical, and send the patient over to radiology for a CT and let the radiologist tell us what's wrong with our patient. So, it's a bit of a two-edged sword, because ideally the physician would complete a very careful differential diagnosis and then order the test. What do you think about that?
Ideally, that would be the case. But as you know, we have other pressures from the healthcare system, like seeing more patients in less time, and documentation and insurance pressures. So oftentimes it's easier to do exactly what you just said and send the patient for a scan, because you don't want to miss anything, right? That's also a part of it. It's almost easier because I think our specialty suffers from not enough public exposure. Like the public doesn't understand what a radiologist does or what value we have. And oftentimes physicians don't see us, so they can just click a button and then the patient goes to the scanner and then they get an answer 30 minutes later. So it's tough. It's tough.
One other quick thing. In my office at the medical school, across the hall is the Department of Radiology, the training program. And I occasionally go in and listen to the lectures. And my Lord, radiologists have to be such perfect anatomists. And not only the normal anatomy, but the anomalous anatomy. And I am just astonished by what you folks know in terms of anatomy. I try to pull up my own scans and look at them, and I'm pretty good with plain films because that's what I did for years and years. But, I just am astonished at the knowledge of anatomy that you folks have.
On that note, I think they say 99% accuracy in radiology world is still not good enough, because that means that you're missing one thing per 100 patients, which is really, there's a lot of stress. You have to, you can't miss anything, and it can be stressful, and no one is perfect. And I was probably going to talk about this later, but certainly malpractice is a consideration that radiologists have to consider. It's certainly not as bad as plastic surgery or OBGYN, but because we have to get as close to perfect as possible, something to think about. And that's why I think we trade for so long. Like, there's no way to amass this knowledge and this information in a shorter amount of time, is my opinion. And probably also the reason why people are doing fellowship more and more often now. I think since around 2000, the technology of imaging has improved to a point where you really do need a fellowship to get really, really good at your subspecialty of imaging.
It's also very much a partnership between the ordering physician and the radiologist. Because when I send somebody over for an abdominal CT, I am usually trying to make a decision about whether this patient needs to go to the operating room or not, and to get a surgeon involved. And if you send them back over with basically a normal CT or no acute pathology seen or nothing that explains the patient's pain, I'm then taking that decision and generally releasing the patient home. So it's a very important partnership, don't you think?
Absolutely. And for me, that was a very it's kind of a position of honor to have someone else trust you like that. Like, hey, they're going to take this one data point and then make a decision like that. It's powerful.
We have like 50 questions already for you, Nick. So keep rolling. Yeah, the kids are loving it.
All right. So I talked about teleradiology. So now, radiology used to be banker's hours. It used to be regular hours, Monday through Friday, no weekends, no nights. But that has changed because we have the internet and we have computers. So now you can have radiology reads at all times of the day because, for example, you could be working in Hawaii and then reading scans for a hospital in New York. So you can capitalize on the time difference because it may be the middle of the night in New York, for example, and then maybe, middle of the day for you in Hawaii. And you can kind of imagine like where an American radiologist might be working. They may be working on the other side of the world in New Zealand or India, for example, and be American trained and be licensed, and then be doing teleradiology for an American hospital. So I thought this was incredibly powerful. My family is from Greece. I'm first generation. I grew up going to Greece. And the idea of potentially practicing radiology in Greece was highly attractive. We'll see if that even happens. But, if you want to read x-rays in your underwear, then that is certainly a possibility. Because at the end of the day, diagnostic radiology, if that's what you want to do, is as close as you can get to a computer or a desk job. I also want to touch on work-life balance and kind of career longevity. You want to think about which specialty can I do for 30 years? Because physicians have a shorter kind of career life than other careers do, because we spend so long in undergrad, medical school, and residency and training, and this is kind of lost income potential. So some radiologists are some physicians in general are just working longer towards the end of their career. So you want to think like, will I be able to do this if I'm 65 to 70 or 75 years old? If I had to save more for retirement, or take an extra vacation, or do whatever you want, really. Maybe you have expensive hobbies. So I found that radiology kind of really suited itself. Like, okay, if I'm going to be 50 or 60, and I've always been a very active guy, but if I had to physically slow down on things, could I do that? And you just want to think about burnout a little bit. Burnout is a huge issue in medicine and for physicians. So I think our specialty certainly does value work-life balance, which I thought was fantastic. On that same note, in general, radiology is shift work, meaning you show up for your shift and get through all of the work that is done, and then you don't bring any work home with you afterwards. The exception to that is interventional radiology, because they do take call, because there are oftentimes emergencies that can only be treated by a interventional radiologist. For example, a gastrointestinal bleed that needs to be embolized, which basically means that the interventional radiologist goes exactly to where the patient might be bleeding from and then cuts off the blood supply, and then basically could potentially save the patient's life. So if you like that adrenaline, or the adrenaline from the emergency department, then by all means, go for it. But this is kind of the emergency doctor needing a scan the minute before your shift is over as a radiologist. And this is where it's nice, because it's shift work, like I said, and it's not like you're going to be hiding behind this tree here, not reading the X-ray or the CT scan. You will, the X-ray or CT scan will come into your work list, and then you'll read it, and then it may take you 2 or 5 minutes, or it may take you 20 or 30 minutes. But you're not, staying 2 hours after your shift, or 3 hours after your shift, doing, working up the patient like you might, if you're on like internal medicine or a different specialty that does not have shift work. So that was pretty cool that you can kind of get through the work and turn over things and then kind of move on with your life. So a few non-medical aspects. I've spoken a lot about the medical aspects of the specialty. So we see it could be anywhere from 100 to 200 different types of scans per shift. This can be a mix of ultrasounds, CT scans, X-rays, and MRIs, typically. So we'll see kind of a scattering of all of these. Of course, if you're fellowship trained in one specialty over another, you might be seeing more MRI or CT than, I don't know, ultrasounds, for example. The typical hours are kind of, in residency anyway, it's right around 50 hours a week. So certainly higher than average for the average 40-hour work week, but it's not as bad as other specialties that may be working closer to 80 hours a week. Call is also a little bit different. So when we're on call, we are on, like, physically working. And on call in radiology simply means that you're working like an evening shift, like let's say from 5 p.m. to 11 p.m., or you're working like an overnight shift, like 8 p.m. to 8 a.m. or 11 p.m. to 8 a.m., for example. And it's not like you are asleep with like a pager and then like only like answer it like if it goes off. Like you are like working, like getting through the work list. You're like on, right? Because you can't really miss anything as a radiologist. So that's kind of how call works. As far as vacation and salary goes, I think these are possibly taboo topics to talk about, but I think they maybe shouldn't be, because, of course, burnout, like I talked about, is a huge issue. Also, physician suicide is double the baseline population rate. So that alone tells you something about maybe the trauma that physicians endure in the hospital, as well as the stressors that they have on a daily basis. So I think the vacation and salary is on the upper end of physician earnings, which I think is an extreme positive, especially if you have student loans. It's definitely something to think about. So I kind of talked about academics versus private practice earlier, and kind of rural versus urban, but I'll talk a little bit more about that. So if you are in academics, that means that you're probably at a large university medical center. And if you're in radiology, typically if you're fellowship trained in, let's say, musculoskeletal radiology, then you'll be doing primarily musculoskeletal radiology at that university setting. So maybe 90 to 100% of your time will be spent doing that. In private practice, for example, which is the majority of radiologists, about 90% of them are in private practice, you'll be doing maybe 25 to 50% of your fellowship. So if I'm trained in neuroradiology, I might be doing a lot of brain scans for maybe half of that time. And then the rest will be kind of getting through the general work, the x-rays, the chest x-rays, the ultrasounds of the belly, for example, the mammograms. You'll kind of just help get through all of the work. So it's nice because you can be highly specialized or kind of be somewhat specialized and then also be a generalist at the same time in a more private practice setting.
Hey, Nick, one of our students asked a question. So how do radiologists manage errors in diagnosis or misinterpretations of what they analyze?
Oh, that's a good question, isn't it?
In a perfect world, they would never make an error.
Exactly. And hopefully that's where artificial intelligence will step in, is, to minimize errors. There is, so the way we learn in residency is basically we take the studies, we open the studies and dictate them and say what we say as far as like what we think is going on. And then the way we learn is by making mistakes and talking with the attending. So the attending will teach you kind of where your knowledge gap was. So that is one way so it's just kind of a learning mechanism, right? As far as attendinghood, I can't really speak as to how it works as a radiology attending, but I believe that there has to be some sort of formal professional feedback, because otherwise it would be really easy to really get down on yourself, I think. And it's extremely important to get feedback when you do miss things, because everyone misses things. I don't think there's a radiologist who doesn't miss anything. And they say if you're not missing something on your reads, then you're probably not reading enough. So it's kind of a careful balance of enough volume and like helping enough patients, but also, kind of your accuracy. You don't want your accuracy to dip so much over time because you're reading so much. So it's kind of a delicate balance of kind of benefiting humanity, I think.
Have you ever had a case where you missed something rare because it looks similar to more common conditions?
That can certainly happen. So I'm at the end of my intern year right now, and I've only done 2 months of radiology so far. So my experience is extremely limited compared to someone who even has a year of training under their belt. So maybe I'll have a better answer for you in about a year's time when I have a little bit more full-time radiology training, because really the only way, people say this all the time, so I'm always asking, like, how do I prepare for radiology as an intern? And really there's no way to prepare. It's one of those things where you just kind of get into it and you're just immersed in it and kind of learn by osmosis over time. Okay, so on that same note, also compare rural versus urban. So oftentimes you'll find large academic centers in the more urban environments, and then you'll find more community hospitals in the more rural environments. And so similar to the private practice versus academics kind of dichotomy, as far as how your practice of radiology will differ, we have a similar difference here. So in more rural areas, like let's say North Dakota, salaries may be extremely high because the demand of radiologists is extremely high and the supply is very, very low. So on that same coin, a more rural radiologist is more likely to be a generalist and less likely to need a fellowship in order to practice radiology. So basically, if you do a fellowship, which is 95% of the time the case, it's easier to work at a academic center or in a more urban environment, even in private practice. So just some things to think about when you move forward with your medical journey. So malpractice. So malpractice is a topic in radiology that should also be addressed. So I think numbers 1 and 2 for malpractice are plastic surgery and OBGYN. They are the most litigated specialties, is my understanding. Radiology, I think, is medium high on the list of specialties that are sued, and no one's perfect. And I think it's just part of the practice of American medicine these days. Dr. Fowler, I don't know if you have more to add to that, but it's it's tough.
What's the specific point you're making, Nick?
Just that malpractice is something to consider in the specialty, but it isn't as bad as some people make it out to seem. Some people have told me don't go into radiology because you'll miss things and you'll be sued for that, when the reality is that there are other specialties that are litigated at much higher rates.
It is generally said in emergency medicine, my field, that you will get a suit about 1 out of every 20,000 cases, which is about once every probably 5 years or so, maybe 6 or 7 years. I'm working in Texas now because what's called tort limitation, which is the limitation on malpractice, is by the legislature, is a very strong limitation. And as opposed to in Georgia, where I worked for 23 years, where it was a much more litigious state. And so it has a lot to do, I'll shut up with this, Nick, of just being very, very careful. We are dealing with human life. On every single, I'm sorry, one last comment, Nick. On every single chart in that big, busy ER that I'm involved with, I sit down and have a focus moment, and I look at everything on that chart one last time. And I make sure that I'm as confident as I can be. Generally, people sue you because they get mad at you. And so it's important to be a good doctor, be a nice person, work well with the staff. But you have to be, one has to be, as a clinician, in an error avoidance mode. Don't make a mistake. And it's a challenge. And that's why med school and residencies are so darn long. It takes a long time to learn this field.
Absolutely agree with all of that. We are dealing with, I think there's, I talk about mental health and burnout and all of these issues in medicine, but there really is no way to divorce the stress, I think, with the practice of medicine, because we are dealing with human lives, right? So lives literally are at stake. It may seem like it's not the case if you're sitting at a computer reading x-rays, but it really is the case. So I think just being a physician is stressful. So I guess I'll wrap this up by saying that instead of focusing on the negatives of medicine and people being depressed and burned out, I think it's just important that we develop our coping skills in how to manage this. People ahead of me have had malpractice case, or there are radiologists who have been sued, and everyone gets past it, right? And I think most cases are actually in the favor of the physician. And even more so, kind of like how Dr. Fowler alluded to, even more so if the patient likes you, if you had a good bedside manner, did you touch them? Did you listen to them? So I think these are all things to consider.
Let me comment, Nick, let me comment on that. I try to go in the room and sit down and often hold the patient's hand for a number of reasons. I'm taking their pulse, checking their skin moisture and temperature. But I approach the patients, closely, not improperly, but because I think the patients, most of them want that. And they want to know that you're really taking the time to listen.
I can't tell you how many times patients have told me my doctor or nurse practitioner or physician assistant didn't palpate me. They didn't touch me. How are they supposed to know? They just sent me on my way to get my test. So thank you for sharing. All right, so work-life balance. So how many weeks of vacation do we take? So I'm just sharing this because this is, again, from Medscape. It would not be uncommon for radiologists to have more than 6 weeks of vacation. There are certain contracts that you might be able to land, especially in more rural areas where demand is extremely high, where you can have upwards of 12 weeks of vacation. So I think it's this is a thumbs up for me. So I think another specialty that rivals this or is similar to this would be anesthesiology, another wonderful specialty. So do radiologists feel fairly compensated? So this is kind of where we land, which I think is excellent. If you look at these percentages, maybe it's not all amazing, but I think that's pretty good. So let's talk a little bit about procedures as well. So this cartoon is kind of talking about how, I'm wise. Is this the med student? Are you the see one, do one, or teach one? Because we have this saying in medicine where you see a procedure or a patient, and then or you see a couple, and then you do one or a couple of these types of procedures or surgeries, and then now you're able to teach it. So there's a lot of really fast-paced learning, and so you might not think of radiologists doing procedures, but we do a lot of procedures. So if you're in musculoskeletal radiology, you might be doing things like joint injections, where you're putting a little bit of steroids in someone's joint in order to alleviate their pain. You might also be doing bone biopsies, where you're taking a biopsy from the bone in order to diagnose a certain type of cancer. In neuroradiology, you might be doing something called the lumbar puncture, where we use fluoroscopy or an X-ray machine in order to see exactly where we're putting our needle in order to draw some cerebral spinal fluid or brain and spinal cord fluid, in order to test that fluid and see if there is some sort of infection like meningitis or some sort of inflammatory or autoimmune process happening. If you're in pediatric radiology, you might be doing a procedure called an intussusception reduction. Basically, this is where the kind of intestine gets really tangled and kind of telescopes on itself. And this can be an emergency. So you might not think that a radiologist might have to take much call, but the pediatric radiologist might have to take call at a pediatric hospital in order to take care of this with a procedure called a contrast enema. In abdominal imaging, a common procedure would be a CT-guided abdominal abscess drain. So an abscess might be like a collection of pus that might be infected, and we might be able to put a little tube in there through the belly in order to drain that. So a radiologist would do that using imaging to kind of figure out exactly where they are going and exactly where they're putting their tube in order to drain the abscess. So in breast imaging, we might do ultrasound-guided biopsies. Lots and lots of biopsies in breast imaging. Interventional radiology is a fantastic field. They do over 200 different types of procedures. I've listed just a handful of them here. You can take a screenshot of this and Google some of them. They're pretty cool. It's an extremely advanced specialty. The best way I can describe it is that if you want to be a minimally invasive kind of surgeon, using imaging or radiology to guide exactly where you're going to see the anatomy, then this is the field for you. Interventional radiologists have clinic and they do procedures nonstop. Oftentimes you can do interventional radiology and then have a job as an attending where you do 70% procedures or IR work and then 30% diagnostic work. So it's pretty cool because you can kind of mix things up. So on that point, why do you want to do IR? Well, you get to do procedures. It's really cool to work with your hands. It's very satisfying. But at the same time, you might get tired of that. It's extremely exhausting to wear lead and to be on your feet. You have to wear a lead-lined scrub cap, lead-lined goggles, a thyroid shield that is lead-lined, of course, like a shirt, and then a skirt in order to protect your gonads and your entire upper body. So it can be physically demanding as well. So if you're wondering, what does it take to be a radiologist? Well, it takes about 14 years after high school. So I took 2 gap years, so that means 16 years total. That means 4 years of undergrad, 4 years of medical school for your medical degree, and then you have basically 6 to 7 years of residency that you train. So you have that first year, which I'm at the end of, and then you have 4 years of radiology residency, and then you have 1 year of fellowship. So we have 6 years of residency total, basically. My intern year is a transitional year. This is a type of intern year that is a mix of surgery and medical rotations. So for example, we rotate through the emergency department. We also rotate through psychiatry, OBGYN, pediatrics, internal medicine, trauma surgery, et cetera, and so on. I'm currently on neurology. And there are other intern years where you're doing mostly internal medicine rotations. And there are other intern years where you're doing mostly surgical type of rotations, where you're rotating through the surgical intensive care unit, through the burn unit, for example. So there's different ways to kind of get this experience of being a young doctor in your first year, kind of learning how to become a physician. Then you start 4 years of radiology full-time. So this is kind of where you immerse yourself and learn everything via osmosis. And then all the fellowships that I've listed here are 1 year, with the exception of neurointerventional radiology. So what is neuro-IR? So that basically means like you're a minimally invasive neurosurgeon because you are taking stroke call and you're able to treat strokes as an interventional radiologist. And there are other types of doctors that do similar work, like neurosurgeons and interventional neurologists. So they're all able to take stroke call as well. And this is a 2-year fellowship. So you might be in residency for 6 to 7 years. There are multiple ways to get to interventional radiology if that's what you're interested in. There's the pathway where you apply directly after medical school. That's 6 years total. There's also early specialization in interventional radiology where you kind of start on the diagnostic track, and then in your second or third year, you hop over to the IR track, and then that is also 6 years. And then you can also do 5 years of diagnostic residency, so 1 + 5 + 4 is 5, and then you could do a 2-year fellowship. So that's 2 years of only IR work. So that'd be 7 years total. So those are kind of the pathways to get to IR. So the fellowships we have are musculoskeletal, neuro, abdominal or body. We have breast imaging, pediatrics, nuclear medicine, and then IR and neuro IR. So I am currently at Hennepin County Medical Center for my intern year, and then I'm technically a University of Minnesota employee, and I got here by going through the master process as a medical student. So that's kind of how residency works. All right, so residency basically works by, when you're a resident, you basically open up the study and then kind of give your impression about what you think is going on. And then you kind of staff out with the attending. You talk about maybe what you missed or what you got right, you get some feedback, and then they say, I'm going to make some minor changes, and then finalize a report and send it out to the ether. And, sometimes you just have to learn by seeing what you're attending, what their style is, and how they structure the report, and what types of words are they using, and maybe what you missed too. So sometimes there's a lot of this feedback where they're like, delete this, delete that, and there's a lot of changes. But this is where you do your learning. So this is kind of how diagnostic residency works. So what about artificial intelligence? So pretty cool topic, very, very exciting. So this is Dr. Cellini. He is an interventional radiologist in New York City. He's a YouTuber, so check out his YouTube channel. He did a pretty cool video on this. I thought he did a really good job addressing this topic. So people have been saying that AI algorithms will replace the doctor since 1976. I think there's a New England Journal of Medicine article in 1976 talking about how hospitalists or internal medicine doctors will be replaced by algorithms because all they do is interpret data points and then come to a conclusion. So obviously this is oversimplifying things, and hospitalists have gone nowhere. They're still they're not replaced by the algorithms, right? Regardless to say, they are, AI is a very, very exciting field of research. We actually kind of already have it. We have it in computer-aided diagnosis, or CAD, in mammography. And if you talk to breast imaging radiologists, they'll tell you it's not that great. It's not. It's got a lot of ways to go. And here I've listed some of the hurdles that need to be addressed before we even start thinking about AI replacing the radiologist. Really, what it's going to do is probably enhance the accuracy of the radiologists and make us better at taking care of patients, like improving outcomes. So we have things to think about, like bias. These algorithms are inherently biased because the humans who are building them, we are biased. We are not perfect beings. These biases kind of trickle into the algorithms. And then if you ask the tech people, how do you solve for this? Well, their answer is more AI. I can create an algorithm to correct for the bias that is already in the algorithm. So it's kind of a funny thing. It's like asking the surgeon, what is the answer here? How do we fix this problem that was caused by surgery? And their answer is more surgery. So, of course, the AI algorithms have to be explained. They are kind of this black box. So we don't really know what is happening inside of them. You feed in data and then you get some sort of output. So there's this explainability crisis, I think. Also, they need to be reproducible. The scientific method needs to be reproducible, of course. Are the tech companies and the startups who are creating these algorithms, are they going to want to share them, their proprietary technology, with each other? Who's going to oversee it? Who's going to take liability? how about, when things ultimately glitch and are hacked, how is it going to be implemented physically into this, or digitally into the software? There's already like a IT infrastructure that we have in place called the PACS system. Who owns the data? Is it the hospital? Is it the radiologist? Is it the private practice radiologist or the corporate radiology company? Is it the algorithm that the company that developed the algorithm, because they are seeing all of the studies that come through? And ultimately, is this even clinically relevant? And what is the context? One algorithm that is extremely accurate for, I don't know, pneumonias, let's say, for chest x-rays, it will have many different metrics to consider if this algorithm is being used in the US versus a country where, let's say, tuberculosis is much more common, for example. So there are many more variables that I've described here, but there are a lot of hurdles, and there's other lower hanging fruit to take care of, I think.
And Nick, also, can you do research on the data? Human subject research is complicated, but if you have thousands and thousands of studies just sitting there on a hard drive on a computer, why in the world can you not do research on it? And the answer is you can't. You have to go through all of the institutional review board study and permissions to be able to do that. My own hospital is tough to get a study through. Keep going.
Absolutely. There's a very, very formal process of going about research. I'll touch on these two topics. So artifact is like when you see a scan and the patient may have a little bit of metal in their body, and then there's a lot of like kind of scatter of radiation, and so that can kind of disrupt the resolution of the image. So are these algorithms being fed scans that are imperfect, like the real world, where patients have hardware and they have post-surgical changes, like they had a surgery and then their anatomy is changed? Or are they only being fed like normal anatomy or kind of easier, so to speak, scans to kind of learn, if that makes sense? So you'll find in clinical practice, a lot of patients have post-surgical changes that are extremely, extremely complex, especially if they've had multiple surgeries and are extremely sick or have very, very rare diagnoses. So a lot of things to think about.
Nick, you called it artificial. I call it assisted intelligence because it really isn't artificial. In my world of the ER seeing patients, there was an article I read recently that talked about that physicians by and large are lousy at making rare diagnoses. They may have never seen them. They might have read about it sometime a long time ago. And as my old pappy said, common things are common. You just don't think of the rare diagnoses. And I believe that in the world of, at least my clinical world of being with the patients and so forth, that there will be some sort of assisted intelligence software running within the medical record that will help us in our differential diagnoses. I think that's going to be coming in a tidal wave.
I agree, and this is kind of my next point here, is that assisted intelligence will ultimately supplement the radiologist to improve patient outcomes. So what radiology looks like today is going to look dramatically different in 20, 30 years down the line. And so someone may come to the conclusion like, oh, that's kind of scary. I don't really want that. Well, I looked at that and I was like, oh, that's actually really, really cool. AI is here. It's here to stay. It's going to change the practice of medicine at large, likely. It's going to be used for probably scheduling purposes, like scheduling patients and scheduling studies at first, for even triaging studies. Like, imagine if there's a list of 20 scans to get through, or 10 or 100 or however many, and you can use an algorithm to kind of briefly triage the list, and maybe it might pick up something that it thinks is something that is life-threatening, like a bleed in the brain. Well, it may flag that and then move it to the top of the list so that a radiologist will be able to get a read on that faster. So triaging studies, I think, is a low-hanging fruit. And at this point, they have very, very narrow application uses. So, of course, common things are common. Maybe there will be an algorithm for very rare diseases because they only present in certain ways, and that it may be extremely useful for this one thing. But in a radiologist's mind, you you can ask them like how they got to their line of thinking and why they think it's one thing over the next thing, and which differential diagnoses they think is most common. Like, what are the 3 most common things that this thing might look like that you are seeing on imaging? What are the 3 most common things that it might be?
So Nick, I read a couple of years ago in JAMA that 2 CT scans of the abdomen gave you as much radiation to your body as if you stood 1 mile from ground zero at Hiroshima. We use an enormous amount of ionizing radiation, and I'm wondering if you think that there will be an imaging moiety mechanism of the future, MRI possibly, or some other imaging yet to be determined, so that we will not use ionizing radiation. I don't want to take a lot of time on that, but have you thought about that at all?
That's a fascinating proposal. The current doses of radiation that are used have been optimized for the, first of all, the machine that you're using. Of course, there's different brands of scanners. There's Siemens and Philips and GE. So the amount of dose is optimized to give the lowest dose possible at this point in time. But of course, things can change. If something else better comes along, we can get the same sensitivity and specificity. I think that can certainly be a possibility. I was talking to a family friend who's a retired pathologist, and he was a medical student, I think he was saying in the 1980s, right when MRI was on the upswing. And he just found it amazing that now we have this tool of MRI to look inside the body with so much detail. So I just think something like this will just be another tool that comes along in the future that we'll be able to implement. So
you've been going for 1 hour and 20 minutes. Do you want to take a sip of water or something, or are you doing okay?
Doing okay. I have some bubbly here. Thank you.
Okay.
This is fun. I hope you guys are enjoying this. So I talked about litigation earlier. So the robot is saying here, I missed a diagnosis. What do I do now? Sorry, buddy, comes with the job. So you also want to think about, what would a patient want? What would my mom want? What would, this is kind of the evolution of things, right? Things happen and then things go away. Transcription is going away. We had plain films earlier, and then now we have digital films. So we'll see if the end of the human race or the human radiologist is over here. We'll kind of see where things go. I think it's very exciting. So here's some misconceptions.
Nick, I don't. Maybe I'm just opinionated, and I am opinionated, but I do not see how Robbie the robot can roll into a room and carry a dialogue out with many of the patients that I carry dialogues out with. Now, having said that, having built-in translation software on a robot will be good, because I'm frequently doing, histories and physicals in Urdu, Arabic, and Mandarin. And computers help us wonderfully, on translation software. But people can be such lousy, patients can be such lousy historians about their own medical history. I think there's going to be a human hand in this for a long, long time.
Yeah, people talk about the kind of softer skills and the emotional intelligence, and how these skills will be even more important. They're already extremely important, but they will be even more important in the future of medicine, because we're going to have tools like these to really sharpen our clinical acumen. All right, so some misconceptions that hopefully I've addressed so far. So radiologists are not all socially awkward introverts. We do see patients. Reading imaging is not easy, as you will shortly see. And not all scans have ionizing radiation. So ionizing means that it can cause cancer. Ultrasound MRI does not. And AI, I do not think will replace radiologists in the future. I think it'll supplement them. This is a funny cartoon here, radiologists in therapy. It's like, you know what, doc, you and I aren't that different. We both see right through people. So
I heard, hey, have you heard the difference between an extroverted radiologist and an introverted radiologist? An extroverted radiologist looks at your shoes while he's talking to you. I'm sorry, keep going, please.
No, I like that. So this is my halfway point. We'll stop and take some questions. I know it's been already a good amount of time, and so we'll get through these scans and these this anatomy fairly quickly. So any questions right now? I'll just check the chat here.
Well, we got bunches of what you want to pause for questions now? If so, Ani, take it away. I know you got about 50 of them in there.
Oh yeah, no, we got a couple of good questions. I guess the first question, a couple of DO questions. Do you think the gap between DO and MD is sort of closing? And for you, how was your experience going to radiology residency from a DO program compared to traditional MD program?
Yeah, the first question, I do think that the gap is closing. The next question, what was my experience like? That's a good question. So you will find that, so I'll preface this by saying a physician is a physician, whether they have MBBS, DO, MD, or any other sort of physician medical degree that's equivalent to that. So at the end of the day, it doesn't matter. It does matter a little bit. So there are some things that you guys should know about. So, and none of these things even matter until you have at least one acceptance to a medical school. This medical school might be an MD school, might be a DO school, might be a Caribbean school, but you just need one school to get accepted to. Now, if you have a choice, then this is where this question matters. So even before you get anywhere, you have to at least get to med school, right? Before you start thinking like, which one do I pick? So if you look at which graduates make it to the most competitive specialties, these are things like plastic surgery, neurosurgery, ear, nose, throat surgery, vascular, urology, interventional radiology is very competitive. Radiology is kind of a medium high on the competitive list. Of course, dermatology is extremely competitive. Those specialties are easier to get into. And by easier, I mean more MD graduates at the very, very upper echelon of medical schools, like top 40 schools. I'm talking about the Harvards, the Yales, and the Stanfords. Those graduates have less of a hurdle to get there than do Caribbean graduates or DO graduates. So it's just, it is what it is. I don't know the reason for that. Thankfully, radiology has a good amount of osteopathic graduates in the specialty. So I didn't really, no one ever made me feel lesser. I was never bullied, if that's what anyone's wondering. No one ever told me my medical knowledge was insufficient or lacking. So my answer to the question is get into a medical school first, and then if you get into both a DO and an MD school, then consider this question more heavily, because either way you break it down, most medical graduates will go into primary care anyways. It just happens that a higher percentage of them from DO schools happen to go into primary care. So
I'll tell you, Nick, I've been working with DOs for over 40 years. I know of no difference between MDs and DOs. In our emergency medicine residency incoming class that just showed up on campus, of 22 spots this year, we accepted 7 DOs. I know of no difference. I think that functionally, knowledge-wise, et cetera, I think they're the same. Plus, you know, osteopathic care, which I don't.
Certainly, you get another tool of osteopathic manipulation that you can use. So if that's something you're looking for, then you can certainly choose to go the DO route. Of course, when you're choosing between medical schools, there's other things to think about, like location, cost, I think is a huge consideration. What does this school's match list look like? What do their board scores look like? Where are these graduates matching? So it's not only MD and DO. I think you also want to look at other things. I think really where the pedal comes to the metal is like if you make it to the Harvards and the Yales, right? That's if you're in a top 40 school. I mean, you're gonna have a different experience than basically every other graduate, and that's my opinion. Just because of kind of the pedigree and alma mater, networks, connections, letters of recommendation. You know what I mean? So I think that's just how it works, and nothing I could do to go to a better school at this point, or to have gotten into a better school. I had 2 acceptances, both at osteopathic schools, and I'm extremely happy with my decision to go to this one over the other one because of those factors that I talked about, like location, price, and residency match list. So,
and you're training at one of the best institutions in the world. So, I mean, you've done just fine. Go ahead, Ani.
Awesome. Another question that someone had asked is, what sort of made you realize that radiology was sort of the right fit for you? Was there like any one moment, or was it just, a culmination of different things?
Yeah, it wasn't any one moment. It's one of those things where you realize it over time. It just happens, you have to perceive it at some point. So I perceived this like, oh yeah, I should probably do radiology somewhere halfway through third year of medical school. So I did radiology as my third rotation in medical school. And then I did the rest of those core rotations like OBGYN, pediatrics, psychiatry, surgery, internal medicine, and family medicine. And I still found myself thinking about like, oh wow, being a radiologist is still actually a really, really cool job. And it's super interesting. I could really see myself thriving in it. And then I got more experience in it. And then I kind of realized like, okay, these are the personalities that I'm driving with. So it was kind of a gradual realization. So very rarely do you just do one thing and then you notice. And you'll do reflection and introspection, I think, throughout your third year. I mean, I had no clue what a radiologist did before medical school. I would kind of see like other doctors like calling the radiologist, and just I had no idea what they did on a daily basis. But I think my culmination of experiences kind of led me here, because I worked at that Google Glass startup in San Francisco prior to medical school at Augmetics. And then I did some computational biology research when I was in medical school. And so I kind of had this interest in tech and digital health. And so radiology is, I think, as close as you can get to that.
Pretty cool. Thank you so much for sharing. Another question is, we do have a lot of PA students. So I guess the question came up is, can PAs sort of work in radiology? And if so, like what type of roles do PAs have in that field?
Yeah, so PAs can work in interventional radiology where they're doing procedures. And typically these are the less complex procedures. So the procedures that take hours and hours and are on the extremely sick patients, those will be done by the attending interventional radiologists. There really isn't a role for PAs or NPs in the diagnostic world, because I think the reason for it is because you have to train for so long. You need to dedicate 5 years of residency just to radiology. So you won't really find PAs doing diagnostic work, like giving the impressions in the report, for example, especially on CTs and MRIs. That's not to say that they won't get really good at reading X-rays and ultrasounds, for example. You certainly could, but not so much in the diagnostic radiology world.
Here's another question that sort of relates. It's a little funny, but does the amount of darkness sort of hurt your vision over time? Being stuck in a dark room.
Well, that's a yes or no question, so I guess my answer is no.
You wear like blue light glasses, or what's your opinion on that?
Yeah, so if you ask the ophthalmologist, do blue light glasses work? The Academy of Ophthalmology says that they don't. Some people will wear them. It's the harm to benefit. There's no harm, right? Mm-hmm. So even if it's placebo, you can still wear it if it helps your if you feel like it helps your eye muscles relax. Certainly, you could try it.
So here's a question. So with incidental findings in the ED, will radiologists be the consult to verify these findings, or?
Yeah, it depends. So generally, incidental findings, depending what they are, will be listed in the body of the report. So there's kind of the body of the report, and then at the very end is the impression. Like, this is the take home of what any provider, physician, NP, PA needs to know about the care of this patient. So if it's an incident, it depends, because if it's an incidental finding that is, let's say, a normal anatomic variant or a nothing burger, like nothing to worry about, then we'll just put it in the body, comment on it, And then if someone else notices on it, they can go back to the report and read through it and kind of understand like what it is. If it's an incidental finding, let's say a patient got a scan of their head for trauma. Let's say they slipped on ice and hit their head, and then you found that they had metastatic cancer to the brain, then that would be an incidental finding that's highly relevant to include in the impression, for example. So it depends.
Another question that someone asked is, do radiologists sort of help in surgery, or do they like participate in sort of surgical procedures as well?
Yeah, that's a great question. So I think the closest that radiologists get to surgery is in the field of interventional radiology, where you're doing minimally invasive procedures. Basically, you use a small little hole, use an ultrasound to gain access, and you can kind of thread this like catheter, this wire, through vascular access to go into any part of the body that you can imagine. Might be the kidney, might be the liver, the GI tract, the brain, for example. So you might get access radially or through the groin, or other ways to get access. As far as interventional radiologists, they work very, very closely with the vascular surgeons. So I think vascular surgery and IR probably have the most intimate relationship as far as collaborating with other surgical specialties. I talked about neurointerventional radiology earlier, so they would collaborate the most with neurointerventional neurologists, so people who are neurology trained and then learn interventional work, or with neurosurgeons. So they have very similar skill sets, but it's just like a different background of how you get there. So there will be a lot of physician collaboration kind of surgically in those specialties.
That's awesome. I guess a follow-up question to that is, so in terms of like, I guess in interventional radiology, do they spend more time with patients, you would say, than computers, as opposed to like other sort of fields and subspecialties in radiology?
Absolutely. Not only because they might have one clinic day a week where they're seeing patients for an entire day or a half day, but because a lot of the procedures that they are doing, the patients aren't intubated and completely anesthetized. They are actually lightly sedated. So this is the case for most interventional procedures. So you can touch the patient and talk to them and see how they're doing. So it is a very intimate patient interaction, I think. Yeah. So my answer is yes.
Awesome. What's it like being an intern? Someone had asked if you could post a day in a life on your TikTok, and that'd certainly be interesting to watch.
So I did. Maybe 5 months ago, and I got like 150,000 views. It was like my most viral video. So definitely check that out. If you go to my Instagram, actually, I post like these mini vlogs. I post like maybe once a day or once every other day, just kind of detailing like, hey, this is when I'm going into the hospital, or this is when I'm leaving, just so people can get an understanding of what my days are kind of composed of. And then I'll talk also about like the types of cases that we see, the procedures that we do, the patients that we interact with, the specialties that we interact with. So if you go to my Instagram stories highlights, you'll see a lot of kind of the rotations that I've been doing throughout the year, which is pretty varied. There's a lot of variety. You'll see kind of more of this day in the life stuff there, I think.
Awesome. So whoever asked that question, be sure to check that TikTok out. It's already been posted. All right, we'll do maybe one or two more questions, and you can sort of carry on with the rest of the presentation. Someone asks, how many hours do you like work per week as a practicing resident, and do you feel fatigue often or occasionally?
Yeah, so it depends. So it depends on the month, because if I'm in a rotation like trauma surgery, then there are days where I have to take 24-hour call. So that means that I maybe get 1 hour of sleep. So you might imagine that the hours add up pretty quick. So it might not be uncommon for a surgery rotation to have upwards of 80 hours a week of hours worked. So this is in contrast to other rotations that I've had, maybe like psychiatry, where it's more around 40 hours a week. And other rotations like emergency medicine or internal medicine might be more around 60 to 70 hours a week. So do I feel tired or not? Yeah, I feel tired, but I don't feel burnt out. And you kind of get used to the grind, right? You get used to getting through all the work in the day. You have your routine at night, like how you relax and stuff. So, I don't feel burnt out or anything. And thankfully, everyone, I think something that's extremely important is having a program that is extremely supportive of you at work. You don't want to have a lot of malicious personalities. It's extremely important to work with good personalities, good people who care about your well-being too. So we're always asking each other at work, between the interns and between the senior residents and the attendings, like, can I do anything to help you if like I'm caught up with my work, or vice versa? So there is, I think, something that I really like about being a resident doctor now is kind of the interactions between the resident to resident interactions. It's very very collaborative, not collaborative, but we're all kind of on the same page. We're all just trying to learn as much as we can and get through the day and do the right thing for the patient, right? So it's a very relaxed kind of relationship like that. So it's pretty cool.
Awesome. I guess you guys have like a little bit of a support system, knowing that you guys probably go through the same thing. That's awesome. And then I guess last question, and then I guess we'll move on to the rest of the presentation. Someone asked how your startup sort of contributed to, I guess, your work in medicine, and if you still sort of engage with that as a resident right now.
Yeah, so it was not my startup, and I don't interact with it now. I still kind of keep up with it here and there because I have some friends who still work there. I wanted to do medicine even before I started working there, but once I started working there, I got more exposure to working hands-on with other doctors, because I would basically help them get onboarded with the service. So I would teach them how to put on the Google glasses, how to use it, how to interact with the software, how it works generally with like our IT department, and making sure that the Wi-Fi signal was good in their clinic, et cetera, and so on. So it was a really, really unique experience. So it definitely contributed to my confirmation that I wanted to still become a physician and not kind of take this more, entrepreneurial or
It's a technical.
Yeah, just a different, different path. Because I would work with, a family doctor or an orthopedic surgeon who's in clinic, and I'd be like, wow, like this person's amazing. Like they know so much, and they're helping people in like moments where they're like in pain and like really suffering, and this person's really sharing like their deepest secrets or like very, very personal stories, right? So I was like, I think I still want to do this. So
Awesome. Well, thank you so much for those very interesting and detailed sort of answers. I mean, we all sort of definitely got a lot out of those. If you want to continue on with the rest of the presentation, and we can, I'll go and ask you the rest of the questions towards the end of the presentation.
Absolutely. So here is a chest X-ray. So the chest X-ray that a radiologist sees is not labeled beautifully like this. So this is from this Instagram page, The Radiologists. Excellent, excellent page if you want to check them out. Here we have the anatomy. So we'll start by looking at the trachea here. And then we have the clavicles that come in here, right? Clavicles are bones, right? Trachea is the airway. Then it kind of comes down here towards the carina, where it kind of bifurcates into the left and right, like the bronchi, like where the lungs kind of go. They kind of branch like trees. And then these are the lung fields here. So they're filled with air. So air is, it's not very dense, especially compared to something like a heart or a bone. So air is black on X-ray, or lucent, or radiolucent. And if something is more dense, or radiodense, or radio-opaque, then it is more white. So here we can see kind of the cardiomediastinal silhouette. This is the left ventricle and the right atrium kind of abutting here. So you can see the kind of diaphragm coursing this way. Then this is the right side, and then this is the left side. So hopefully this kind of helps you guys get oriented. So this is kind of where the liver might sit, and then this is kind of where the intestines and stomach might sit, or the gastric bubble. Then you can see all these ribs kind of coursing through, and then the scapula over here, of course. So this is just kind of a basic framework kind of going forward, and we'll talk about some basic anatomy, some cases. So here's another beautiful overlay. This is another awesome Instagram account, the Radiology guy. You can see kind of the vessels of the heart here. Of course, this is not labeled like this when you see a chest X-ray, but this is the anatomy that we have to keep in mind when we go forward with reading an X-ray. So of course, trachea coming down, superior vena cava coming, superiorly, of course, and then the inferior vena cava coming up here, draining into the atrium. Then we have the different lobes of the lungs here, and then we have the stomach kind of hanging over here, and the spleen is over here on the left. So of course, left and then right, and then of course the liver again, and then the diaphragm here and here. So this is a CT scan of the chest. So there's different ways to kind of look at anatomy on a CT scan. So this would be kind of a coronal plane. So if you can imagine this blue plane kind of cutting through patient's chest here. And then there's other planes like this, the transverse or axial plane, where it kind of goes up and down. And then there's the sagittal plane that goes left and right. So these are all anatomy things that you'll learn in medical school. And again, this is very similar anatomy that we saw on the chest X-rays earlier, but this is a CT scan, so you get a little bit more resolution and detail rather than the more areas of gray like in the X-rays. So again, the trachea, bronchus intermedius, left main bronchus here, aorta, pulmonary trunk, or the vessels that go to the lungs. And we have the different lobes of the lungs again, liver again, stomach again, spleen, diaphragm, etc., and so on. So here's the first case. So this is a chest X-ray. Here we have a positive arrow sign, which is kind of a joke in radiology, where the arrows are pointing to something that maybe should not be there. So this is a 65-year-old female. I'll kind of talk you guys through this case, and then we'll kind of develop a differential diagnosis. So she has a history of chronic obstructive pulmonary disease. This is lung disease, most commonly caused by smoking. So we have a 65-year-old female with COPD, and she presents to the emergency department with fever, so elevated temperature, shortness of breath, or dyspnea, or difficulty breathing, as well as sputum production. So the sputum happens to be yellow and green in color and has been going on for about 3 to 4 days. She has what's called pleuritic chest pain. So what does this mean? So this means that when this patient is taking a deep breath, that they are having pain when they inspire, when they breathe inwards. And this pain happens to be on the patient's right side. The patient also has something called tachypnea, and this means that they're breathing fast. So their respiratory rate is elevated. So the respiratory rate might be 30 breaths per minute, and that's fast. They also might have tachycardia, which means that their heart rate is elevated, so their heart is beating fast. And if you take a stethoscope to their lung fields on their chest, you might hear something called crackles. So this is kind of a crackling, popping sound, and you might hear it on the right side, especially if you auscultate with your stethoscope on the right kind of lower part of the lungs. And if you decide to order some sort of blood work, then you might decide to order a complete blood count, or a CBC. And something that's part of the CBC is called the white blood cells. And those might be elevated in infection or inflammation. So when the white blood cell count is elevated, that's called leukocytosis. So just kind of getting all these clinical findings here, this is maybe a step where at this point in time, someone might order a chest X-ray, and then this is the finding that we would see. So given everything that we see so far, what is your guys' differential diagnosis here for maybe what might be happening with the patient, or what most commonly would be happening with the patient? So some people here are saying pneumonia, and you guys are nailing it. Some people are saying COVID. So I'm glad people are saying COVID. That's a great answer. So here we have a right lower lobe opacity. So again, opaque means that it's more dense. So it's in the right lower lobe. Again, this is right side, and then in the lower lobe. So this is all consistent with a bacterial pneumonia. Of course, there are other types of pneumonias. And depending on the type of pneumonia it is, that can change the type of treatment. So the treatment for pneumonia might consist of something like IV antibiotics and a hospital stay. So speaking of COVID, here is a CT scan of COVID-19. So we have findings here called peripheral ground glass opacities. Here we see some vascular dilation. So these vessels are a little dilated. Ground glass opacities basically mean like junkiness in the lungs where junkiness should not be. So this is some consolidation, maybe where the lung parenchyma or the lung tissue is consolidated due to the pneumonia. This is kind of what a pneumonia or COVID-19 pneumonia might look like on a chest CT scan. So good job, guys. On to the next case here. So here we have a 58-year-old male. Of course, we have the chest x-ray pulled up for us here already. We'll kind of get through his history. He has a history of CAD, so that's coronary artery disease or heart disease. So he's also presenting with shortness of breath or dyspnea or difficulty breathing. He has something called orthopnea, which means that he has to breathe with, like when he's laying in bed, he has to use 2 pillows in order to raise himself up in order to improve his breathing. So it's called orthopnea. His respiratory rate happens to be 30 per minute. We talked about tachypnea earlier. So this is an elevated respiratory rate, kind of breathing fast, basically. His oxygen saturation is 90%. So usually we would like that to be over 95%, depending on who you talk to. If you put a stethoscope up to this patient's chest wall or lung fields, you might hear something called rails. If you order blood work, you might order a biomarker called a BNP. And this is highly specific for certain finding that we'll talk about in just a moment. So this is called a brain natriuretic peptide. If you don't know what that is, that's okay. You'll learn about it in physiology. So kind of what's the differential diagnosis here, given kind of the findings that we have here on chest x-ray, et cetera, and so on. Let's see what you guys are saying here. All right, people are saying fluid, good. CHF, yeah, that is a lot of fluid, isn't it? Pulmonary edema, you guys once again nailed it again. So this is something that we might describe as fluffy bilateral opacities. They are perihilar. The hilum is kind of right here. They are maybe a bat wing or angel wing configuration, kind of like that. And this is all consistent with pulmonary alveolar edema secondary to congestive heart failure. So this patient also has cardiomegaly. So the cardiac silhouette is very enlarged here. The heart's very, very big. It's very weak. So this is heart failure basically causing fluid to back up into the lungs. So the way we might treat this is possibly with something called diuretics or IV Lasix or furosemide, which some of you may have heard of, in addition to other treatments. So also briefly touch on why radiologists want 2 views. So oftentimes we say 1 view is no views. So when we get an x-ray, the x-rays that we saw were only head-on or AP or PA, antero-posterior, right? So we also want side views, and I'll show you why in just a moment. So we can sometimes get tripped up if we only see like a certain finding from 1 view. So this is a side view. Sometimes things can hide behind the sternum here or hide behind the heart. So retrosternally or retrocardiac opacities. And because you're looking at a 2-dimensional image of a 3-dimensional human body, it's difficult to triangulate where in 3-dimensional space this, let's say, pneumonia might be hiding if you don't have 2 views. So the takeaway here is 1 view is no views, really. So you always want to get 2 views. And again, the importance of the lateral view or the sideways view is extremely important because you might get tripped up if you're just looking at it from one way. So another thing we also do as radiologists is look at the prior. So we always pull up the imaging that has been done previously on a patient. So this is, Pam from the office. Corporate needs you to find the differences between these pictures. And these are 2 chest x-rays. And then, she's just saying that there's no difference. But yeah, always important to see what the previous, let's say, chest x-ray looked like in order to compare it to the current one and see what changes have happened, or maybe if there have not been any changes. So we also see metallic objects. So these objects can be radiodense. This person's asking, what kind of surgical hardware is this? Maybe able to tell that there's something kind of here. Maybe you guys can guess what it is. And this cartoon is saying it's bra straps. So sometimes we see bra wires that kind of course like this. And sometimes we see surgical clips or sternotomy wires when the patient has had some sort of surgery where their chest was opened up. So we see all sort of metallic objects. This is a hand x-ray. I'm just going to go through quickly some anatomy here. So you can see all the anatomy that we need to know. Of course, this would not be labeled once you're a practicing radiologist. I'll just go through some imaging here to give you guys a flavor of the types of studies that we see. So we see studies from all of the human body. So this is a C-spine, so cervical spine, plain film or x-ray. This is a x-ray of the shoulder. So we have the humerus here, of course. Of course, we have so much more anatomy to look at and consider. We have a elbow x-ray here. Of course, there are nerves and vessels that are coursing through all of this, but x-rays are generally really, really good for bones and to see if a bone is broken or dislocated. Here's an example of a breast cancer, and you can kind of see the pectoralis muscle here, over here. Then this is the axilla. So again, breast imaging is part of our specialty as well. Moving on, we have an ultrasound here. So you can kind of compare ultrasound to what we've seen so far. Ultrasounds, maybe the resolution is a little bit fuzzier, a little bit less crisp, but we use it to take a look at the liver, at the kidneys, at the gallbladder, at many, many different types of organs. So we also use it a lot in pelvic anatomy for our obstetric and gynecologic patients. Here's a CT scan of the abdomen. Here we see the liver really nicely. We see the right kidney, the left kidney. Sometimes you might see a kidney stone, for example, causing the patient low back pain or flank pain, and hematuria or bleeding blood in the urine, for example. We see the stomach again, the spleen. We have the psoas muscles. So you can see kind of the intervertebral discs here. So CT scans give you a lot of spatial resolution is the way we call it. So now we're in the abdomen here with a abdominal x-ray. Again, same anatomy, different study. So this is a x-ray. Again, same organs, right? They all sit in the kind of the same spot. And the abdominal x-rays are generally ordered for to rule out like bowel obstructions, because sometimes the colon or the small bowel might be extremely dilated, and that would be indicative of a bowel obstruction. Here we see some tubal ligation clips. So what does this mean? So this means that someone may have had their tubes tied in order to prevent further pregnancy. So abdominal x-rays are a relatively frequently ordered study. So since we're still in the abdomen here, this is again a cross-sectional or axial view of the abdomen. Again, many of the same organs, right? This is the left side, and then this is the right side. Again, left side, right side. So the liver hanging out over here, the gallbladder is colored green for us. We have the stomach, pancreas kind of coursing along the, coursing over the midline here. You see some blood vessels here, the inferior vena cava, aorta, and then the kidneys, of course, and then the spine and the vertebrae here. So again, more abdominal anatomy. Moving onwards to another type of study here. This is a MRI. So I want to compare an MRI to a CT scan for you guys. So we have the same anatomy, but with different kind of crispness. So an MRI would be really, really good for soft tissue, is what we call things like spinal cord. It'd be really good for that. And I'm just giving it as I'm just showing this as an example to kind of compare to a abdominal CT scan. MRI is also used for taking a look at the prostate gland. Sometimes the prostate can get really, really enlarged, and prostate cancer is also very common in our elderly male patients. Since we're down here, this is a pelvic x-ray. Oftentimes emergency doctors will order these because it can be, it's not uncommon if a trauma patient, for example, has some sort of hematoma or bleeding into the space, because a lot of blood can be found in the space. And this is just a quick and easy way to see if there might be something there that we can see. Of course, the bladder sits here, and you guys can kind of imagine the rest of this anatomy. So oftentimes patients put things where maybe they should or should not be. So what could this be? So this happened to be a cookie jar. Sometimes radiologists make a joke saying in their impression or in their report that they suggest that the doctor clinically correlates. So this is kind of our way of copping out and saying like, we don't know what this could be, but go figure out what it is. So yeah, sometimes you see things like this. This is kind of a joke. I don't think this is actually real. This is also a joke, but this is a joke from maybe a few months ago. I'll let you guys see if you can make it out here, kind of what's sitting here. And then, as a joke, of course, you would never actually say this, but, clinically correlate with the rectal exam for this one. But hope you guys find these memes somewhat entertaining and kind of enjoy this type of thing. I'm just going to take a look at the chat here.
Nick, you have a sense of humor. That's totally fine.
Good. All right, so more radiology, just giving you guys a flavor for this type of stuff. This is what's called an abdominal aortic aneurysm. So sometimes if this gets large enough, we need to treat this surgically. So, all right, moving on to you might hear people talking about a slip disc. Well, this is maybe what that might look like. It might cause people talk about sciatica. Well, sometimes patients have pain that is radiating down their lower extremities, and we call that radiculopathy. And sometimes that can be caused by a nerve root being compressed by a slip disc, kind of like this. So moving kind of downwards into the body, now we're in the knee. So again, x-rays are really good for fractures and dislocations. Let's say this patella was a high riding patella, maybe it was like up here. Then we might think that the patellar tendon was ruptured, for example. So, with certain findings, we can kind of figure out kind of what's going on. This is, again, just the knee anatomy labeled for everyone. So the tibia here, of course, the femur is coming down, the patella, condyles here. And you guys will learn all of this anatomy in medical school. Moving down to the foot here, of course, there are vessels coming down here, and the foot has a good amount of anatomy here that you'll memorize, cuneiforms, cuboid, navicular, calcaneus. They have kind of funny names like this. And patients don't always know that, that when something is fractured, that means that it's broken. So when you're talking to patients, just let them know that they kind of understand, sometimes they'll think like, oh, doctor told me it was broken. I didn't know that that's the same thing as a fracture. Or like someone told me that it was fractured, but I don't know if that's broken or not. So I think it's always good to go back to the basics and kind of meet patients where they're at. So I just thought I'd share this meme. So now we're moving on to a little bit of neuroradiology, neuroanatomy. So this is an MRI of the head. So here we have all the lobes nicely labeled. Cerebellum. You guys may have heard of some of these organs or some of these parts of the brain called the corpus callosum. This connects the two hemispheres. Here's the ventricle, the thalamus, midbrain, pons, medulla, etc., and so on. You may have heard of the pituitary gland or the master kind of hormone gland. This is, again, the same anatomy, just labeled a little bit differently for you guys. And then here we'll finish with two kind of straightforward cases. We'll go relatively quickly through them since it's been a while. So here we have a case of a 45-year-old male, and this patient has a history of head trauma. So what does that mean? This patient may have been in a car accident or slipped on ice and fell and hit their head. And this is a CT scan of the head. So we would order a head CT without contrast. And these are the same scan with kind of different software processing. So this is called windowing the scan. So here we see something, and we'll talk about it in just a moment. Then here again, we see something that is lens-shaped, kind of like a lens, or lenticular-shaped, and it's hyper-intense. So this is more intense or more white than the brain parenchyma here. And this is in the left frontal region, right? This is the left side. This is the right side. And here we see a fracture of the left frontal bone. So this is going to be a classic case of a certain diagnosis that you'll learn about in medical school. And if you don't know what it is now, then that's okay. But kind of at the top of your differential for a classic board question would be a epidural hematoma. So epidural means that it's sitting on top of the dura. The dura is a layer of the brain, basically. And a hematoma is a collection of blood. So this is a collection of blood secondary to trauma. and oftentimes is associated with a left frontal region fracture. So, all right, last case here for you guys. So here we have brain MRI. We see the arrows, of course, pointing to kind of help us. This case is a case of a 40-year-old female. She's having blurry vision for 2 weeks. So keep in mind this age and this demographic. So being a female at this age with blurry vision is kind of classic for the diagnosis that we're about to discuss. So she's also presenting with ataxia or difficulty walking. So the radiologic findings that we would describe this with is that we are having these kind of lesions here, or foci. So we can kind of see them here. This is the ventricle. So one way we can describe them is periventricular, or around the ventricle. They're kind of globular, which kind of means that they're kind of like globules or like irregular circles, kind of smooth. And at this point, I think if you hear about a 40-year-old female with blurry vision and difficulty walking, this would be classic for multiple sclerosis. And in MS, you may know someone with MS. Oftentimes patients have these plaques, which you can see on imaging. So this would be MS plaques. So yeah, I just thought I'd share kind of a common diagnosis here. Here is a really quick kind of video of a 7 Tesla brain MRI. This is completely normal human anatomy. This was donated from a 58-year-old woman who had no history of neurologic disease, but died in the intensive care unit from pneumonia because she was severely immunocompromised. So her immune system was down because I think she was being treated for some sort of leukemia. So her brain was donated to research. And so this is a fantastic contribution to research because we basically, the researchers basically scanned her brain in an MRI scanner for 4 days or 100 hours, I think, at a time. And so they continually scanned it and got this incredibly high resolution image here. And so if you take nothing else away from this, all you need to know is that when the MRI scanner, of course it's called magnetic resonance imaging, when the magnet in the MRI is higher Teslas, that means that it's more powerful. So the magnetic field is more powerful. And that means that we can get higher detail or higher resolution. So sometimes a neurologist will want higher resolution on their MRI scan for their patient. So they may request a high resolution MRI scan, like a 3 Tesla instead of a 1.5 Tesla. That happened to be a 7 Tesla. So more Teslas, more detail. So if you're still interested in radiology, I'd encourage you to check out all of these resources here. I think this is a fantastic blog right here. The Amster Society, they have an incredible guide if you want to match into radiology. Go ahead and take a screenshot of all this if you want. The Undifferentiated Medical Student, fantastic podcast. Director One, this is more geared at radiology residents. It's a question and answer blog, fantastic information. Of course, here are some people that you can connect with on TikTok and Twitter and Instagram and YouTube. And I really encourage you to reach out to people because social media community is very, very positive so far. So some people think radiology is easy, but it's not all black and white. You know, there's a lot of gray area. So that kind of concludes my presentation. And I'll finish with kind of this funny tweet here from Dr. Shadow Gazer, who's on Twitter, hilarious, saying that, you know, what are all those lights in the sky, Daddy? They seem to be moving, you know, and the radiologist is telling their kid, well, when a radiologist, dermatologist, or ophthalmologist finishes their first year of residency or their intern year, they package their stethoscope up into the sky and launch them into orbit. Isn't it beautiful? So if you aren't enamored with using your stethoscope, then that is okay. There is a specialty for you. So let me know what you found the most interesting, what you learned, your favorite case. You know, like and comment and share this video if you found value of it. You know, give me a follow. Go ahead and check some of the content that I posted for you guys, and feel comfortable reaching out. It is my never humble opinion that radiology is the best kept secret in medicine. So thanks for having me, and maybe we'll answer some more questions here.
Nick, what a great talk. That was terrific. You okay? You sip of water for a second before we take a couple questions?
Yeah, doing great.
All right.
Thanks for asking.
Ani, give us 2 or 3 more questions, then we'll call it an evening.
All right. I'm actually just sifting through the the document and seeing some questions I can ask. So if there's ever a patient that isn't able to get a certain scan, let's say they're not sort of compatible with a dye, if they want to do CT scan, or if they have a device that doesn't allow them to go in a scanner. So how would you sort of deal with that?
Yeah, great question. So an MRI scanner has a magnet. So there are certain items which we call them a ferromagnetic. That basically means that if they're near a magnet, then it is very dangerous. So that's why we ask patients, like, have you ever had any shrapnel in your body, or like worked with like machinery where you have like metal in your eyes, or do you have a pacemaker, or some sort of cochlear implant for your ears, et cetera, and so on. So sometimes you're able to get around those, even if the patient says that, yeah, I've been shot, like I may have a bullet still retained in my body or something, because you can do kind of like a scout film, or you do like a scout x-ray first to kind of see if there's any metallic objects in it first. And then that can kind of inform your decision to go through with the MRI or not. So there are some circumstances where you can't, where it's contraindicated, where you can't do it. There's some kind of debate about kidney disease and giving contrast for CT scans. So I'll refrain from commenting about that, but there are certain clinical situations where you might want to think twice about that. But there is some literature just coming out now that maybe contrast-induced nephropathy or kidney disease is not what we thought it was previously.
This one question, I guess, refers to one of your case studies. Is there a lasting effect on the frontal lobe? And this is talking specifically about the epidural hematoma.
A lasting effect. Well, if it's not treated, certainly. You might want to call a neurosurgeon for that one, for sure. It depends. Sometimes patients will have to go through rehab and kind of have a long-term prognosis that may, shoot in the positive trajectory. And sometimes they will not be able to regain full function depending on like how bad the bleed was, and also like where the bleed was, right? And what type of surgery they had, and whether they had complications from the surgery, and whether they're compliant with their follow-up appointment and their medications, et cetera, and so on. So hope that kind of answers that question. That's a tough one.
And I guess one or two more questions. Someone had asked, how do you foresee sort of imaging changing and improving cancer intervention in the future?
Well, with cancer, I think screening tests is really where, well, first of all, you want to focus on prevention. So one way to prevent cancer is to never to get it. One example of that would be with the HPV vaccine that prevents cervical cancer. So you can always start there with the vaccine to completely prevent it, or dramatically prevent it. After that, we have screening tests. So a mammogram would be a screening test, right? Because we're looking for early stage breast cancer in order to treat cancer earlier, because the earlier you treat it, the better the outcomes are. I think this question is kind of talking about the future of radiology. It's hard to comment on exactly what direction screening tests for cancer will take, but I only see imaging tests used for screening cancers to increase. So, for example, sometimes patients do not want to have a colonoscopy, which looks for colon cancer and then takes it out. So now we have a radiology test called colonography, where we can take like a virtual look into the colon, into the intestines, to see if there's something that would be suspicious for a lesion. Of course, it's not as good as a colonoscopy, but if you can offer something different to the patient, I think that's always a positive. So.
Awesome. Thank you so much for sharing.
Yeah.
Dr. Fowler, do you have any sort of last questions that you wanted to ask?
Oh, just Nick, what a great talk. Let's everybody put thank you Dr. Parisi into chat just to say thank you for what a great talk he gave with us. Well, Nick, you had over 300 people sitting on the edges of their cheap seats tonight, hanging on every word. This was terrific, and I thoroughly enjoyed it. It brought out what I admire so much in radiologists, which has, been all of my long career. We generally have as many as 5,000 people that'll watch these videos because, as you know, we're going to post it on our YouTube virtual shadowing site. Each one of them will be a medical practitioner and see 100,000 patients in their career. 5,000 times 100,000 is 500 million. Nick, tonight you touched 500 million lives, and I hope that you feel that it was a good time for you, and just want you to know how amazingly grateful we are for your kindness and taking all this time out and away from your wife and the smoky kitchen. Just kidding. Having smoked up the kitchen plenty of times myself. But anyway, Nick, thank you. And so everybody, we just thank you for coming tonight. What a terrific session. On behalf of the whole virtual shadowing team, half of which are about to move off to med school, we just want to thank you for coming, and we appreciate it very much. Ani, do you want to show them the exam thing?
Yes. Dr. Parisi, if you could just stop your screen sharing for a minute, and then I can share my screen real quick. So here's the quiz information. As always, it's going to be due 1 week from now, right before the start of our next week's session on Tuesday. So it's going to be 6:22, right before our session starts, and you get 2 attempts. You just got to score 70%. And be sure to download the certificate after you finish the quiz. That way you can save it for your records.
Thanks, Ani. And again, Nick, thank you so much for taking the time out this evening. We sincerely appreciate it. Best of luck in your program. I know you're going to go far, and I hope maybe one day your path finds its way down to Texas. So anyway, thank you everybody for coming. What a great evening. We thoroughly enjoyed being with you, and we look forward to seeing you in the near future for our next virtual shadowing session. So on behalf of Dr. Parisi and on behalf of the whole working group team, we wish you a good evening and a good night.